Good afternoon and a very warm welcome to you all to this evening's event. It's a real pleasure to welcome you. My name is Mai Krishnasamy and I am Director of the Academic Nursing Unit at the Peter MacCallum Cancer Centre and hold an honorary chair as Professor of Cancer Nursing at the University of Melbourne. I'm also fortunate enough to hold a position with the VCCC as Research and Education Lead for Nursing. So before I go on and introduce tonight's speaker, I would like to acknowledge the traditional custodians of the land on where we are all situated this evening. I'm on the land of the peoples of the Kulin Nation, and I would like to pay my respects to elders past, present and emergent, and extend that respect to other Indigenous Australians who may be with us this evening. So it's my real pleasure this evening to be chairing the session. And so just so that we get as much as we can out of the evening, just a couple of rules before we kick off, our housekeeping rules before we kick off. We are recording the event tonight, and so it will then be available to view on the VCCC Alliance website. If you have any questions for Sue Bartlett, tonight's presenter, please do that via the Zoom Q&A function, and we'll have an opportunity at the end. You can put those questions in as Sue goes through her talk, and then we will curate them and try to get to as many as possible of your questions later on after Sue's finished her presentation. So it's now my pleasure to introduce Suzanne Bartlett, known to many of us. Sue is Symptom and Urgent Review nurse at Ballarat Regional Integrated Cancer Centre. So Sue's worked as an oncology nurse in various roles in metropolitan, regional and rural settings. She completed her Masters of Nurse Practitioner in Medical Oncology at the University of Melbourne in 2018. She's been a nursing representative on the VCCC Alliance and Monash Partners Cancer Consortium, Cancer and COVID-19 Task Force since its commencement in March 2020. And Sue is the chair of the COVID-19 Task Force Oncology Nursing Expert Group, and it's in that capacity that Sue is speaking with us this evening. So the Expert Nursing Group is currently reviewing the needs of the oncology nursing workforce across Victoria and looking at the potential impact on service delivery as a consequence of the surge that we're now seeing in response to the COVID pandemic. So I know that many of you have been looking forward to this presentation. So Sue, welcome and thank you very much, and I'll hand over to you.
Thank you very much for the introduction, Mai, and for the VCCC Alliance for inviting me to present tonight on the COVID Nursing Expert Reference Group. So I'll just share my screen. So just a bit of a background about the Victorian Cancer COVID-19 Network. It was established in March of 2020 as a statewide collaboration which involved multidisciplinary clinicians and multiple healthcare services across the state. And it was to share knowledge and experience of caring for people with cancer during the COVID-19 pandemic. The Victorian Oncology Nursing Group, as part of the VCCC Network Task Force, was established in late 2020, and it's a subgroup of this task force. The task force chairs are Professor Grant MacArthur, who's the Executive Director of VCCC and a medical oncologist at Peter MacCallum, Associate Professor Zhi Wan, which is Head of Oncology at Peninsula Health, Associate Professor Suzanne McLaughlin, who's the Director of Oncology and Cancer Services at St Vincent's, and Associate Professor Andrew Hayden, who's a medical oncologist at Alfred Health. So the focus of the VCCN Oncology Nursing Expert Group was to really review the current and future needs of the enablers of the oncology nursing workforce in Victoria. And it was to identify opportunities for growth and improvement of education, training, and dissemination of resources and tools. It was also to develop guidance and strategies regarding the impact of COVID-19 on the oncology nursing workforce and how we can support the profession. We wanted to advocate for the investment in oncology nursing to ensure successful utilisation across the cancer community, which was underpinned by a strong evidence base. And we also wanted to identify key opportunities for research and education in oncology nursing. So in our membership, we have myself as chair, Kate, who works for WICNIX, and she's the program manager of the group. And then we have 20 members who represent nursing from all the integrated cancer services in the region. So for anyone who is on tonight who's not from Victoria, Victoria is split between regions, and an integrated cancer service represents each region. And so it was paramount that this nursing group had representatives from all the integrated cancer services, both in metropolitan Melbourne, but as well as regional and rural Victoria. So within this group, we have a circ nurse, which is myself. We have a nurse who works on the 13 11 20 Cancer Council Victoria information and support line. We have representatives from both metropolitan and regional palliative care services, the same in radiotherapy. We have HIT and chemo in the home representation, oncology education, haematology, both inpatient and ambulatory care, day oncology and chemotherapy day units, medical oncology, and VCCC and X representation. So we've tried to make it really broad and try to really make sure that every specialty area within oncology was represented, and talking about what the current challenges are when we meet on a monthly basis. So the surge planning, the background to this was we knew there was a significant drop in the cancer notifications between April 2020 and February 21. We also knew that prostate cancer, melanoma, breast cancer, head and neck and haematology tumour streams were the most affected within these cancer notifications. And we anticipated that there was a spike in the undiagnosed cancer cases and cases of advanced disease. We also knew that this period of deferral of care that was occurring during the COVID-19 pandemic was expected to cause a significant increase in new cancer cases with more advanced disease, anticipated to put the Victorian Cancer Services under increased pressure, with possibilities such as pandemic-related travel restrictions and people seeking closer care to home. Uncertainties persisted around access to appropriate cancer treatment and the capabilities of services to cope with a surge in referrals. And we also knew it was becoming clear that regional and rural patients may want to seek treatment closer to home rather than commuting to Melbourne. And anyone who is from Victoria is very familiar with the Ring of Steel, and you know that was something that we lived with for quite a few months last year, and that certainly impacted regional patients, but also patients that were living on borders between Victoria, New South Wales and South Australia within the state to access treatment. So between April 2020 and June 2021, the Victorian Cancer Registry data identified a significant decrease in cancer pathology notifications for several tumour streams. And so we know that the Victorian Cancer Registry received 6,538 fewer pathology notifications than was expected. And this is estimated to be approximately 3,037 undiagnosed tumours as a consequence. Breast and colorectal incidence data show that these estimates are most likely underestimated. And I wanted to acknowledge Sue Evans, who has been very generous in sharing her data for tonight's presentation. And we also knew by looking at this data that when we broke down the different tumour streams, that these were the significant cancers that were undiagnosed. So you can see with breast cancer, haematology, melanoma, head and neck and prostate. And so what we discussed in a previous slide earlier in the presentation. So this was a breakdown. So as the pandemic and lockdown continues, so as previously said, we know there's approximately 3,000 undiagnosed tumours based on the Cancer Registry current data. For breast cancer, there are a lower number of cases reported in women with early stage disease, which likely reflects breast screen performance over this period. For bowel cancer, there are a lower number across the board, and it's not just the early stage disease which is being missed, and an ad campaign will soon begin to encourage bowel screening. For prostate cancer, there are also lower numbers across the board, and this likely reflects men not prioritising their health checks with their GPs during the last year. So the consequences and context to what we know in regard to the data. So we know that deferrals and non-presentations for screening, care and follow-up will result in a significant increase in new cancer cases at more advanced stages, putting Victorian Cancer Service under increased pressure. We know that pandemic-related travel restrictions, fear of travelling to Metro Melbourne and policy directives for care closer to or at home is shifting the volume and requirement for care to outer metro, regional and rural health services. And the capability of services to cope with a surge in referrals was and is still unclear with the current lockdown. So in response to this data that we knew was being collected on a regular basis, that we wanted to gather information about the state of ambulatory and inpatient oncology services across Victoria. And the aim was to gather information to inform a plan to prepare for the anticipated surge in patients based on the Victorian Cancer Registry data. So we set about putting together a mapping project. And so we developed a short survey from the group and with regular changes and it finalised. And it was emailed to the nurse unit managers of relevant services across Victoria in all the different integrated cancer service boundaries and geographical areas. We wanted to collect information focused on understanding the current capability to identify opportunities for process improvement and proposals for additional resourcing. And then with this mapping project, we met, or I didn't, Kate did. Kate met with the VIX managers in February and put the proposal together, and it was approved to go ahead from the VIX managers meeting in February. So each VIX project staff was contacted to identify key stakeholders that they thought were in their local service area across the state, focusing on oncology services most likely to be affected. And these included chemotherapy day units, inpatient wards with a focus on melanoma, breast, haematology, prostate and colorectal patients, because we knew this was the top 5 tumour streams that were having a decreased diagnosis. Radiotherapy units and centres, palliative care units, including palliative community services in local areas, and symptom and urgent review clinics were identified through the Department of Health, through Angela Mallorik. So this is a breakdown of what we did to establish contacts and distribute the survey. So Kate had a 30-minute Zoom meeting with the nominated staff from each ICS to explain the mapping process and resources. Then the nominated ICS staff from each region used local knowledge and the nursing members list to list services providing the cancer care identified as most likely affected by the surge. And then when establishing contacts, the nominated ICS staff used existing connections to list contact details for each of the services identified. Then when we went out to distribute the survey, the nominated ICS staff developed a template email with a survey link. So each ICS had a different survey link for their area. And initially it was only going to be open for 2 weeks, but we had Easter and a few other things in between that time, so we did extend it for 4 weeks. For people that couldn't access the survey link or had trouble with IT issues, we did offer the availability of a phone interview so that the ICS contact person could talk to the nominated connection and do the survey over the phone. And so that was required for any outstanding responses after the 4-week closure. And then we had a telephone interview script for that. And when we did distribute the survey, so Gippsland, unfortunately, because they'd had some previous IT issues in the past, couldn't open the link, and Grix kindly developed a new link, and we resent it out to, I don't know, 50 plus people out in Gippsland to redo the survey. So it was quite involved. And then the survey responses were exported to a spreadsheet for analysis, and then each ICS received their local health service responses. And then for the benefit of our survey results, all responses were de-identified and shared with the nursing group. So the surveys were distributed via email to 317 key stakeholders by myself, and I would like to make an acknowledgement to Kate, who put everything all together and sent it to me with all the contacts and the links and the survey and the email. So I couldn't have absolutely done it without Kate, so I just wanted to acknowledge all her hard work she did in the background. The survey remained open for 4 weeks, so from mid-March to mid-April, and then we had additional email communication and phone interviews undertaken by the Integrated Cancer Service program staff. Unfortunately, some health services had blocked external links, which Gippsland was included in that, and but we we developed a new link which was enabling people to complete the questionnaire. But unfortunately, in Eastern Health, they had an issue with their IT and they couldn't access this link, and we couldn't develop something in the short space of time. So we tried to do phone interviews when possible, where we could. So this was an example of the survey questions. So we wanted to know the hours of operation, and that was to see the current state and possibility for extending capabilities. We wanted to know how many patients each service saw that were under the top 5 tumour streams that we were expecting a surge of. We wanted to know how many non-oncology treatments were delivered to see whether there was, temporary relocation of non-oncology treatments to another part of their health service. We wanted to know the service accessibility to medical teams. So, do they have access to registrars and residents after 5 o'clock if a day oncology unit wanted to stay open longer? But then also what that meant for regional areas in the state for visiting oncologists that come either weekly or fortnightly, and, and what that meant for them and how they manage their service. We also wanted to see what the current EFT vacancy was like, to see if there was any major workforce gaps. Whether all health services that deliver cancer services had access to an oncology nurse educator, and that was to obviously maintain and upskill oncology specific skills for nurses. We wanted to get an idea of what health services use as a chemotherapy training package, whether they used an own in-house or whether they used the Evercue ADAC. As well as the service occupancy rate. So, was there a capacity to accommodate more patients in their service? And we also wanted to see what the casual workforce was like in each health service. So, if someone had to be furloughed or, had to take time off for whatever reason, was there a resource of casual nurses that were chemotherapy trained or oncology trained that could step up and fill those gaps. We also wanted to know the DNA rates to see if there was a potential for improved efficiency, as well as referral to treatment wait times to preempt the surge that we were all expecting, that we are thinking is going to increase the waiting list delays. As well as pharmaceutical availability. So I know here in Ballarat we get all of our chemotherapy made in Melbourne, but there's, you know, obviously a lot of health services that make up their treatment on site, and so what does that look like if there's a surge or a disruption in services? And then we also wanted to look at the organisational wide oncology services available to see if there was the capabilities of patients having their treatment closer to home with the current restrictions and I guess anxiety about patients, you know, not wanting to travel too far from home. And so when we started getting the data in after the 4-week period, we did, like I said earlier, de-identified the participant data, but it was coded for health services and it was shared with each specific integrated cancer service related to that health service. And that was to identify and inform service delivery gaps and identification of opportunities to collaborate with process improvement projects. All survey responses were completely identified and collated for the final report. The data analysis was undertaken by Kate and it was analysed descriptively. So when we broke it down, there was, as you can see, you know, whether they were metropolitan. So we had 43% of metropolitan health services complete the survey and 57% of regional health services. And then there was a breakdown of all the integrated cancer services. So GICS is the Grampians region, so that region that I'm in. GRIX is Gippsland. BRICRIX is Barwon and South region, so you're talking Geelong right down to Warrnambool. LMIX is Bendigo right up to Mildura. HUMRIX is the Hume area, and then WICMIX is Western Metropolitan Melbourne. NIMIX is Northern Eastern Metropolitan Melbourne, and SMIX is Southern Metro Melbourne. And then we also broke down the data between whether it came from a public health service, so 82% of our responses did come from public hospitals, 8% came from private, and then there was a 10% that came from both. So there are some health services that are a combination of public and private. And then this is the breakdown of the services of the responses that we got. So there was 27% of the responses that came from patient education and planning. 22% of the responses were involved in chemotherapy administration. 16% of the responses were working within palliative care services. 11% were inpatient medical oncology, 7% were radiotherapy, 9% was haematology, plus or minus bone marrow transplant, and 8% was surgical oncology inpatient. So what were the key findings? So most respondents had seen an increase in referrals during February and March 21 compared to before COVID. And this was predominantly noticeable in metropolitan Melbourne and within radiotherapy and palliative care services. A high number of breast care nurses reported that their services were currently operating at over 100% occupancy, which is particularly concerning as almost 1/3 had wait lists longer than recommended. While many services were currently running at capacity of at least 75% occupancy, it also indicated limited potential to expand should demand increase, but regional sites appear to have greater capability to increase and more manageable wait lists than metropolitan sites. Regional health services had far less immediate access to cancer-specific medications, relying on deliveries from off-site manufacturers compared to metropolitan health services. And we also knew that participants reported limited access when compared with metro counterparts to cancer-trained medical staff and access to nurses qualified to work in cancer care. And so in previous slide, I showed some of the survey questions. And so this is a breakdown of the service capacity and capability. And so I guess the the biggest thing that we notice obviously is that regional hospitals had less access to cancer-specific medical teams on site 24/7, that they had only medical staff during operational hours and often used GPs on call. And patient waiting lists were a lot higher in metropolitan Melbourne than regional. And obviously, 22% compared to 4% of metropolitan hospitals compared to regional had their treatment manufactured on site, I guess, which is a big, I guess it included in operational when you're a day-to-day basis, because if you have someone unwell and they can't have treatment, you often have to throw the treatment out. But also at the same point, if you need to have someone urgently have to start treatment, you have to try and work very closely with the manufacturers to make sure that it gets up safely to the hospital. So it's very imperative with the pharmacy team to work out how you make sure that's delivered safely. So with the workforce skills and education information that we gathered from the survey, we knew that regional health services had significantly less availability of and access to cancer-trained medical staff compared to metropolitan health services, and were less likely to have casual nurses qualified to work in cancer care. We also knew there was a variation in nurse training packages used for chemotherapy administration between regional and metropolitan sites. While most regional sites use the nationally recognised and transferable ADAC through Everq, almost half of participating metropolitan health services use their own in-house training packages to deem staff competent for chemotherapy administration. In health services where graduate nurses actually rotated through oncology, many of the specialised services often had graduates want to stay either on a casual basis or apply for permanent positions if they became available. So they their response showed that by having graduates come through, it actually helped their workforce. But we also knew that, in quite a few health services in the state, they do not offer graduate nurse programs, and they didn't offer rotations in the specialised service areas. And this hindered the opportunity to train and attract nurses to specialised cancer care. It was particularly noticeable in chemotherapy day units, radiotherapy and palliative care services, and these are the areas which was anticipated to see an increase in demand and therefore require depth in their workforce. And so when we broke down the workforce skills and education, there was not much of a difference between regional and metro in access to a nurse educator. But we could see between regional and metro, there was a lot higher uptake of the ADAC, and obviously a lot of the metro hospitals used other training packages. And in metro, they have a lot of casual nurses employed who have cancer experience compared to regional areas. So where to from here? So the Oncology Nursing Expert Group has used this report to inform plans to support the Victorian Health Services and nursing workforces in managing the surge in patients seeking care as a result of the deferral of care that occurred during the COVID-19 pandemic. And recently, as a group, we have discussed developing a cancer training package for the non-oncology nursing workforce in hospitals and communities, and have, in collaboration with Peter Mack, put together a grant submission, and we'll find out in December of this year if the grant application has been successful. We have also been working with the clinical directors group. So it's all the clinical directors in the state that manage cancer services. And they are also another subgroup of the task force. And so we're both aware as groups that there's a critical medical and nursing workforce shortage in the state. And so we have been meeting regularly over the last few weeks to try and put together some short and medium-term strategies for both of the disciplines. And we've also approached the Cancer Nurses Society of Australia, which is our professional body for cancer nursing, to work with us in the future in regard to the nursing workforce and the nursing education. And so I've kind of finished a little bit earlier than I thought I would. So first of all, I'd just like to say thank you to all the participants who contribute to our survey, and also to the nursing group, the 20 members who meet. At one stage it was fortnightly, but then it went to monthly. And in the current climate, you know, where it's quite stressful, so we certainly wouldn't be where we are now with the report and the information that we've gathered with the support of the nursing group. So I'd also like to acknowledge the members as well. So any questions?
Sue, thank you very much. It's a comprehensive piece of work, and I think worth noting that, you know, it's probably one of the first pieces of work of its kind for us that, you know, interestingly driven by the needs of the pandemic, but actually offers an opportunity for us in Victoria to take a bit of a step back and take a stock take, which actually we probably needed to do anyway, in terms of, you know, what does our cancer nursing workforce look like? What does it need to look like now? And really importantly, how do we build a current contemporary cancer nursing workforce for not just this generation of cancer patients, but those coming into the future? So thank you so much. I know how much you've driven this work, and how passionately you've spoken about the need to have it done. So thank you, Sue, for that. So we've got one question in the chat at the moment. So please, if you've got more questions through, I'll come to that question now. Some nice comments coming through, Sue, thanking you and congratulating you on the work, and on a wonderful presentation. I might just go, I know there are a couple of Q&As in, and I'm going to control myself and keep myself to the end of the questions, but I'll start with Rebecca. Rebecca put a question in, Zozal put a question in quite early on, asking, did I see the data correctly? Were more lung cancer diagnoses observed than expected? If so, is that because of increased awareness of respiratory health, including signs, symptoms during the pandemic? And Rebecca notes it's interesting that the diagnosis of some tumour types have increased in contrast to the majority which have decreased. So that data around lung cancer, Sue, I don't know if you want to bring that back up. Oh, and have a look at that. So I know certainly from having had a look at the quick slide where Sue finds that, interestingly, in that 2020 data, the lung cancer group were not in that top 5 at that time. Whether that data has changed in the latest slide, Sue, I don't know if you've been able to find that. I can certainly bring it up here. While you're having a look.
Is it, I think I'm on it, so can you see that?
No, we can't, no, but that's okay.
Oh, hang on, I'll share it.
Okay, great.
You see it now?
Yeah, that's great. Thank you. So I think, Rebecca, that was the one perhaps you were referring to, which shows here, where are we? We've got actually decrease in the number of lung diagnoses there. So maybe it was just the visuals on the slide, Rebecca. But if we haven't answered the question, please feel free to put another question in. Sue, I might get you to stop sharing so we can see you again, and then I'll come back to the next question. So I know Catherine Lane's got a virtual hand up, but I'll just go to Heather Cameron first, who says, wonderful work, Sue. Given the pandemic is continuing, will there be a phase 2 of the survey? I wonder if the uptick might increase now that we're feeling the fatigue from the long haul and the long journey. So
we have actually talked about doing a phase 2, and when we met with CNSA probably a month ago, that did come up in conversation. We've probably got the contacts and email links now to do a phase 2, and I think, you know, this year probably hasn't turned out how we thought it would. We were probably in a place earlier in the year where we thought we might have been past lockdowns and getting back to a new version of normal, and you know, I don't have to tell anyone that hasn't turned out the way we thought. So yeah, it's probably, you know, an opportunity to maybe redo the survey again, perhaps, you know, whether we do it later this year or early next year, you know, with 12 months comparative data, and you know, and look at what, you know, a difference of 12 months makes as far as the results. So absolutely.
Okay, thanks, Sue. Important question. Jessica Wilson's put a question here. Do you know how the rapid upskilling program will be made available? So
I might hand that over to you, Mai.
Sure. So Jess, thank you for the question. We've literally just put it in for a funding round and hoping, as Susan, to hear in December. But I think that issue of dissemination is a really, really important question. And, you know, we have, through the richness of the membership of the group that Sue chairs, we have lots of avenues through the VCCC, the VCCN, of MPCCC, of course, of ways of making those programmes available. We also have the new Revitalise regional grant with a huge network right across the Victorian region. So I think we'll have some really strong avenues for dissemination. And I think, you know, we just need to wait and see, fingers crossed that we get the money, and then we'll start having that conversation. But it is a conversation I think we need to have irrespective about how do we make sure that the patients who are coming into environments where we don't have the specialist cancer nursing workforce are being cared for by nurses who have essential fundamental cancer knowledge. So thank you for that question. Sue, a couple more questions here. This is from Gemma Still at CNSA. Great report, Sue. Thanks for the opportunity here. Very keen to see how we can roll this out nationally, given the issues are relevant across all borders. Any ideas from the ERG about how we can address the workforce shortages?
So yes, Gemma, it'd be great to work with you to look at this as a national issue, because you know, it's certainly not just Victoria. I think as a group, when we met a couple of weeks ago, we talked about, you know, potentially having graduate nurses rotate through. One, to break down the barrier of oncology nursing not being this scary thing that sometimes is perceived, but also it gives them an opportunity to get some skills and have an exposure to oncology, and if they do like it, you know, often they come back. So it's training that junior workforce, and then it's also trying to, you know, look at the role of students and how we get students into oncology as well, and also I guess how we support nurses in oncology to keep developing their skills and, you know, looking at further studies and things like that. So I think it's kind of, we've looked at it as a whole layer of nursing, right from junior to senior workforce, and how we can better support that currently and, you know, at all levels. So I don't think there's a clear answer, and, you know, but we're trying to do our best.
Yeah, thanks, Sue. I think that's really important. And I think, Gemma, the opportunity to take the work that Sue's driven nationally is a fantastic suggestion and idea, and I wonder whether perhaps, you know, in a revised survey, one of the questions we could be asking of each other is, what are the models of care that we're using, and are we actually, you know, is there an opportunity for us to be more efficient in the way that we are organising care? And I'm sure that there'll be people on this call, and of course nationally, who you know, will also be doing some really great stuff to think about some of these workforce shortages. So having a national lens on that would be fantastic, I think. Sue, another question for you from Di Davy. The data about the availability of cancer-trained nurses wasn't what I expected. I expected a much lower availability given the closed borders, overseas nurses returning home, and loss of nurses to COVID duties. Can you discuss that in more detail? So the availability of cancer-trained nurses being higher than I'd anticipated.
So I think that probably a lot of the overseas nurses that, you know, was working at the time that we did the survey, either, you know, was still living here and hadn't planned to go home. So it was probably those nurses that were here. However, I think that that if we probably did that survey question now, I would think that the results would be very, very different, because we've definitely lost a lot of nurses to the COVID areas, such as hotel quarantine, contact tracing and vaccination clinics. And I also think we've had an extremely high number of nurses leave the profession through exhaustion, fatigue and burnout. So I think while it was high then, I'm not sure that those results would still be the same now.
Yeah, absolutely. Thanks, Sue. So a couple of more questions and comments coming in. I might just circle back. Gemma has said, CNSA would be very happy to work with the ERG to support a second survey. They're actually looking to do some national surveying work later this year. So that's fantastic. Thanks, Gemma. Commentary here from Liz Schwartz saying, thanks for presenting. Listening in the car on the way home has been great and informative without the slides. So thanks, Liz. Hope you get home safely. Then Delane Smith, thanks for addressing the vulnerabilities of the workforce caring for vulnerable patients. Foundation support groups are also bidding for government funding to increase capacity to support roles who are often targeting experienced cancer nurses. It's a very good point, Elaine. Not sure how we can look at opportunities to leverage her. Did the grant include any sort of shared or leveraging education? So, Sue, I don't know if you want me to say something about the grant or whether you want to...
Yep, you can. Yep.
So, Delane, thank you. The intent with the Rapid Upskilling Programme is absolutely not to reinvent the wheel. We're going to be looking at resources that are already available. What can we repurpose? What can we use? And the intent would be that whatever we develop would be available and accessible nationally, so that we can leverage from each other around programmes that we've got, as well as leverage opportunities for us to learn from each other and share what we've got. So thank you. That's a good question. Sue, back to a couple more questions. So it's great that you've given us time. You've obviously generated a whole lot of thinking. So this is from Kate Slade, thanking you also for a great presentation, saying, was there any input from outpatient surgical units regarding prostate cancer new diagnoses? Many new diagnoses come through via outpatients, never reach the inpatient units, but still require nursing support in that setting.
Kate, in regard to that question, the survey link was sent out to prostate cancer nurses that we knew worked in the areas within the health services. So I guess the results would be very much dependent on the nurses completing the survey and obviously the areas that they worked. So no, it didn't specifically go out to the surgical outpatients, and perhaps something that we can think about if we go on to do another survey, but it did actually go out to the prostate cancer nurses in each area of Victoria, if there was one in each site.
Great, thanks, Sue. So there's a comment here from someone, my apologies, I don't have your name coming up, says some CDUs are planning to extend hours of opening and then makes the very important point that, but of course that requires the staff then to be able to support that. Angela Merrick has put a good question in, but Angela, I'm going to wait a minute because I'm hoping that your question brings in another rush of responses so that I don't miss stuff. I'll come back to that. Susan Munro says, would be interesting to see what the results are in other states. Absolutely, particularly New South Wales, given the current COVID impact there. And so, Susan, thank you. Reference back to that need for looking beyond Victoria, and also thanking you for a great presentation, Sue. So I'm going to come back to Angela Mellerick's question, which is, do we have anyone from New South Wales on the call who can comment on how they're managing in the chemotherapy day units in terms of managing staff furloughs? So we'll just wait a moment to see if some responses come in. And while we're waiting there, Sue, I might take a sneaky chance to ask a question. So I was really interested on the data around, the capability, some organisations already at 100% capacity. And there was a small proportion there, about 18%, who were functioning at less than 75% capacity when the survey was done. 4% of those in metro, below 75%, 14% of regional, and yet it looked from the data as though there was greater capacity in the regional centres, around that, capability piece than obviously in metro hospitals. I'm just wondering whether you think there's an opportunity there for us to think differently about some of the policy stuff, care closer to home and care at home. And what is there something there for us to think about around the fact that metros are maxed out, and yet we know that that's where a lot of the attention is on the workforce?
Yeah, no, absolutely. I think as far as treatment delivery, there's an opportunity, for patients to have treatment closer to home, obviously if it's safe to do so. And I know, like up here in Ballarat, we have patients that have their transplants in either Geelong or down at the Austin. But I know post-transplant, once they've over the acute unwell phase and are coming home, we'll often liaise with both health services to manage patient care close to home. And so I think that there's absolutely an opportunity for health professionals in metropolitan Melbourne to, look at patients' addresses, particularly if they're coming from the country, and asking them or giving them the opportunity to say, look, you live near Bendigo or near Albury Wodonga or Geelong or wherever, I know that they're able to deliver this treatment at this health service. Would you be happy to have your treatment there? Because I think from research data, a lot of patients are reluctant to actually ask for that because they feel so grateful and thankful for being referred to, a health service that, has obviously delivered them treatment that saved their life or extended their life. And so they don't want to then ask, well, can I have it close to home now? Because they're concerned it may come across as ungrateful. So I think, as health professionals, we have a duty of care to patients, particularly now, that if we know they're from the country and we know they, may live closer to another hospital that delivers the same treatment, to give them the choice of, is that something that they want to do?
Yeah, thank you, Sue. And what a fantastic messaging around, the opportunity for us as nurses to advocate and encourage and support patients to have those conversations. And, we could have a whole other conversation about the benefits of tele-intervention and how as nurses we can work together, and I'm sure that we'll have that conversation another time. But thank you, a really important message I think around the advocacy and supporting patients to ask for the care where they want it. Di, just before I come to your question, Di Davey, there's Gemma has says that I haven't had anybody in. Di's going to make a commentary around being at Borden, Albury, but Gemma says she'd be happy to follow up with people from New South Wales. If the person, or if Angela, if you want to contact Gemma, she's very happy to follow that up with some New South Wales members. And so Di Davies saying, I'm at Border Cancer Hospital in Albury in CDU. Some staff have been voluntarily redeployed to Western New South Wales. Very limited capacity for dealing with further staffing losses or furloughs. Right, thanks, Di. So things are, as we know, looking quite sober. And yet I think as nurses, we're always looking for an opportunity in a storm. And I wonder whether this does give us a chance to really think about construction of care. And as you were saying, Sue, that we really, use this opportunity in what potentially is a crisis of the workforce to think about how we restructure ourselves to deliver a model of care that is absolutely about what the patients need and want. So where are we? We're at 6:20. I don't think there are more questions coming in. Grant MacArthur just saying, great presentation and discussion. So thank you, Grant. Very patient focused, well, good data to help plan for workforce challenges, absolutely. And I think that speaks back, Sue, to the encouragement from the questions and the discussions that we've heard to follow on with more work and really keep an eye over time over what's happening here. So if there are no more questions, it's 6:20. I know many of you will have been working from early this morning. We'll give you 10 minutes back, but really want to thank you, Sue, very much for driving that work, for bringing that insight and information to us and giving us an opportunity to progress this important conversation in a very constructive way. To thank all of the expert nurses group members, and to thank all of you who've turned out in large numbers this evening to listen to the talk by Sue and to be so engaged. It's fantastic to see so many people online. Thank you all very much. Sue, thank you, and good night.
Thank you.